Welcome to our first ever Griffin Greats interview series. We're excited to be here and to be able to host alumni from around the world, direct to your living room. We're sharing expertise and Griffinity. So tonight I'm pleased to welcome William R. Stull, MD, from the class of 1982, and our head of school, Adrian Finley Odell. I will be monitoring the Q&A after their chat. So go ahead and ask them on the Q&A, or if you're watching on Facebook Live, I'm looking at that too. So go ahead and ask them there and I'll read them out during that portion. But after that, take it away, Adrian.
Thank you, Sarah. It is so good to be able to have our very first Griffin Great, Dr. William Stull, and to have those of you joining us from all over the place for this wonderful Griffin Great gathering. Unfortunately, this spring, we had several Griffin gatherings planned for alumni around the country, and those had to be canceled because of COVID-19. So we were thinking long and hard about how can we build community in this pandemic, and how can we connect us even in spite of all of this. And what became very clear was that this pandemic has actually fast-tracked everyone on technology and using things like Zoom. So we realized, you know, anybody who might not have been doing Zoom before, they know how to do that now, and it's become pretty easy. So thanks for joining in. And I would love to introduce Dr. Stull to you and then have him say a few words of welcome, and then we'll get into some questions.
Hello, everybody. This is Dr. Bill Stull in Bakersfield, California.
Dr. Oh, sorry.
Oh, no, go ahead. I'm not used to this, doing on the Zoom meeting, so apologize if we're interrupting each other here. I'm in Bakersfield, California, down in the San Joaquin Valley, which is, if anybody here is in the medical field, this is the area of the endemic San Joaquin Valley fever, or coccidioides fungal infection, but otherwise it's a small county in California.
We're so glad to have you with us. And for those of you who aren't familiar with Bill's background, he is a broadly experienced pathologist with expertise in software and programming as well. What a great background. He performs general hospital pathology at Kern Medical, and he's a consulting pathologist for Mosaic Laboratories in Lake Forest, where he previously served as medical director and as a consultant and assistant medical director for Kirshman Diagnostics in Irvine. Other posts include Medical Laboratory Services, Medical Group, U.S. Medical Associates, and Specialty Laboratories. He was also the medical director at AD PathLabs in El Monte, California. In addition to pathology, Dr. Stull has also worked in computer software and programming. He attended the University of Texas Medical School in San Antonio, Texas, and his residency was at Kettering Medical Center in Kettering, Ohio. He also has been at the New Mexico School of Medicine in Albuquerque, the Wright State University School of Medicine in Dayton, Ohio. And I believe your JST was at the Brooks Army Medical.
My sophomore year was at Brooks Army Medical Center in San Antonio.
Well, that's great. So why don't we kind of dive into that? But before we talk about JST, Bill, and about COVID-19, which I know everybody is interested to hear from you about, can you tell us a little bit about your experience as a student at Roycemoor School?
Well, starting Roycemoor, I started just freshman year in high school. So I only did high school at Roycemoor starting in 1979. 3 years at Roycemoor before graduating. At that time, I lived in Villa Park, which is about 20 miles due west of Chicago. So my first 2 years, I commuted in to Chicago Northwestern. So I had about a 2.5 hour commute each way, taking the trains downtown Chicago and then from Chicago up to Evanston. So until the third year, my junior year, I could finally drive, and then it cut down my commute to only an hour. So that was a little bit of a benefit. Made it a little bit easier. Otherwise, I guess it'd be fairly standard high school fare for the first couple of years. I actually then started did calculus at Northwestern in my junior year. That's probably pretty much the basics of what happened at Roycemoor. And of course, for the new, if there's any new students here, this was at the old building. The original Roycemoor facilities on Orrington Drive in Evanston, not at the new facilities now.
Great, thanks, Bill, for that background. And we hinted about your JST, and let me just, for those of you who aren't familiar with the JST, it's one of our signature programs at Roycemoor. It stands for January Short Term, and it provides a deep dive for all of our upper school students. It occurs during the 3 weeks after first semester exams in January. And during that time, all classes are suspended, and students have the opportunity to participate in intensive projects designed by them to explore their own interests. They can explore career interests, learn a new skill, or strengthen an old one. They might even participate in a service project or trying out something that they just are wanting to explore further. So it sounds like you took full advantage of that opportunity when you were a student, Bill.
I did. That's accurate. Give you the full gamut. The first year I did a study in nature in winter with Mr. Spica and a big group. We did some winter hiking and exploration and plant identification, but animal tract identification in the snow and then in the winter. That's up in Wisconsin at the Kettle Moraine State Park. Second year was the Brooke Army Medical Center. I volunteer at the Brooke Army Medical Center is the major hospital system for the military down in San Antonio. And I was volunteering in the emergency room. Spent a lot of time running some errands and such, but was able to observe a lot of the procedures going on. A lot of it's on recruits and basic training. I don't know, cadets or what you'd call, but they would come in, with their basic emergency problems. You'd have broken bones. You would have a lot of hangnails. There'd be infectious diseases that we would see. Some people stabbed by yucca plants, a plant that has very sharp spikes down in San Antonio. So a whole range of medical problems that I was able to observe and actually assist on a few occasions. And then my third year was in independent computer study. So that was the time when computers were just coming out. It's on the old trash 80s, the TRS 80s from Radio Shack. Basic systems, black and white monitors and a little tape drive for memory before there was even floppy disks. Started in right at the beginning of that. So those are the three JSTs that I was involved with in my time at Roycemoor.
Oh, some really vast experiences there.
Yes.
Wonderful.
Different range, just to get a whole range of the things that I was interested in.
Yeah.
And actually that carried forward in my college. I actually majored in both biology and math computer science. So continued on with both of my main interests at that time.
And so did your experience in JST also give you further inspiration to pursue a career in medicine?
Oh, definitely. That was, that I could actually see I wasn't bothered by the blood or by, other bodily fluids and not fainting or anything. So I had actually had the idea of going into medicine at that time. And I had also was volunteering at a local hospital. So I had saw the other side, dealing with patients and feeding patients and bed making, some of the basics the volunteers can do as well.
Well, great. So can you share with us kind of what led you to then your current career and what you're doing today?
Oh, after medical school in San Antonio, that's for 4 years, I went on as actually intended to originally go into general surgery. I did 2 years of residency in general surgery at Wright State University in Dayton, Ohio, until I needed a lifestyle change. And then I switched over to pathology. Did perform 2 years at Kern Medical Center in Ohio, but unfortunately, the way the programs were going at that time, a lot of the smaller programs were closing their doors, so I had to go out to University of Mexico to finish up my residency. So I got to see both kind of a community hospital setting as well as in a university setting for pathology. And then my first job out of residency was at a reference lab in Phoenix. And that was a small lab called oncogenetics. I started in specialized studying with flow cytometry and studies of lymphomas and leukemias, as well as other technologies called immunohistochemistry, in which we perform consultations on cases and slides. That lab was bought out by another lab in LA area. They brought me out to LA. I'd been in Southern California. I actually worked in various reference laboratories for about the first 10 years of my professional experience. And then I moved out of the reference lab setting and then back into what we kind of call the bread and butter pathology, back into community hospitals and performing more of the anatomic pathology. And then most recently, I've been up in Bakersfield now, actually going on 6 years now. So I work at the county hospital. This is a 220 bed hospital, 222, and about 12 ICUs. It's actually the largest and only trauma center between LA and Fresno. So we see a lot of trauma come in from the neighboring communities. Bakersfield itself is a city of almost 400,000 people, and it's the largest here in Kern County. Kern County is about 1 million people, but it goes fairly wide. It goes up. We have different areas. We cover some of the Central Valley, so we'll have a lot of immigrant farm workers. So we deal with a lot of indigent patients. And we also deal with people in the mountains to the east of us, Tehachapi and Lake Isabella. A lot of people who don't have access to medical care up in their communities very readily, especially for larger procedures. And that's so we probably serve an area of easily 1 million people.
So how has your work been impacted since the rise of COVID-19? What has changed for you and your work?
Honestly, not very much. We are not one of the large cities having a lot of impact. We've had a few cases around Bakersfield, only 4 deaths. We've done some testing in our hospital. We've tested probably about 400 people on average. We come up with about a 5% positivity rate. So, we're not comparable to New York or even LA areas. Kern County itself doesn't have a large population density like a lot of the areas who are being affected by COVID-19. And the other benefit is the administrators of the hospital where I work did not shut down a lot of the services. Many of the hospitals, even in California, have stopped doing elective surgeries. They've shut down a lot of their outpatient clinics, but our facility has not. So we have seen a drop in the number of cases coming in, probably a lot likely because people are so afraid they're not going out and having their normal procedures that they should be taken care of. So we have actually seen a drop. Fortunately, our hospital hasn't succumbed as much as the other hospitals. So many of the hospitals have seen such a severe drop that they are laying off people. They are furloughing a lot of their people. A lot of the doctors' offices and outpatient clinics have suffered quite a bit. So actually, the healthcare system has not benefited, and it's not rising up, and we have not seen the need for additional manpower here. At the very beginning of here, many places were calling for doctors to come out of retirement, especially in New York. And they made that call here in California as well, but it has not materialized. And in fact, now with the call for more and more testing, they were sending out emails even to, in California, we call them clinical laboratory scientists or the medical technologists. They're the ones who perform a lot of laboratory testing. They put out a call for a lot of them who have been maybe in retirement or not active to come back. But if you look at what's really going on, maybe the large reference laboratories, mainly Quest Laboratories has been one of the big laboratories in California that's been performing a lot of the COVID-19 testing. They actually laid off about 4,000 people.
Oh, really?
I don't know how many of those were CLSs, but they actually have a lot laid off. And I think a lot of that is not necessarily the COVID, but it's because all the other testing has dropped off considerably.
Mm-hmm.
So there's probably a large percentage of the population who's out there. They're afraid to come out into public or go to the hospital or see their doctors, or their doctors are not available. And ones with the chronic diseases are just not following up. That's one of the things that's actually scaring me about the chronic disease problem, that patients are going to start suffering a lot more because they're just not following up as readily.
Yeah, there's all of these kind of additional impacts.
Yeah, the domino effect that nobody can foresee. And who would have thought that we're going to start having more poisonings in the community? I don't know if you've seen that headline, but there are people now, they're so scared they're using cleaning products, and either they're overusing them or they're leaving them available for children, and we're seeing poisonings.
Wow.
That's increasing. Our hospital has seen actually a little bit increase in overdoses. Unfortunately, also in the younger children age. I guess they're at home, not being supervised, and they still have access to drugs and such, and we're seeing actually like a little increase in overdose cases at this point. Fortunately, not yet for suicides, but who knows what's yet to come.
Certainly a big concern given the mental health impact of all of this. People, being stuck at home, parents losing their jobs or being unemployed or furloughed for a particular amount of time. It's had different kinds of impacts on different families for sure.
Oh, definitely.
And, I worry about where there's been a family that have already had stress anyway. The additional stress going through what we're going through now has got to be really tough.
Oh, it's immeasurable at this point, because we have families who are laid off. We have families, where they're going to stay at home now. They can't go out. I'll try to avoid the political skew of this, but they're shutting down the beaches, they're shutting down the parks, they're shutting down the gymnasiums, the places where people would generally go to maintain their health and have activities for undetermined reasons, to be honest. They have shut down schools, as you know, in most of the places. California shut down small businesses, what they call non-essential businesses, in early March, with no determination when they might reopen those at this point. So there's a lot of people that are still out of jobs, and the economic impact here will be unknown. If a lot of these small businesses will even be able to recover. So even if this business can reopen, they won't necessarily have the people be able to come back. We have had some people moving out of California for that reason too. But when you do have people locked up at home, start seeing more chronic problems, alcoholism, drug use, I'm sure it will lead to more domestic abuse, child abuse. We're just not seeing the spike in that yet, but just starting to see a little bit of an overdosing.
Yeah, a lot of stress.
Yep.
So, one of the things I would love your take on has to do with kind of the facts, the what's the truth or fiction related to some of the things that people are talking about right now. during COVID-19. In Evanston recently, they've instituted, and in Chicago, instituted a mandatory mask wearing if you're out in public and you can't maintain social distancing. And certainly some people have gotten really upset to the point where they've kind of knocked people over if they weren't maintaining their distance. They get really irritated, and understandably so, in grocery stores and things like that if they haven't done what they've been asked to do. But I'd love your take on the masks and what that does for us, why we should wear them. Can we, for those of us who don't work in the medical profession with our kind of made at home masks, should we wash them frequently, or like how should we operate on a day-to-day basis?
Okay, if I may, we'll step back just a little bit. I unfortunately don't know the background of everybody that's here. I'd like to give a little bit of basis first on the virus, and then we can delve into questions like on the face, if you don't mind. As everybody's aware, we're talking about COVID-19. It's actually now called SARS-CoV-2. It's a virus, and if people don't know what a virus is, it's a microbe that requires coming into a person's body and entering the cells for it to metabolize and divide and grow. It's not like a bacteria that can take over and you can be treated with antibiotics. A virus you cannot. But the virus will gain entry through certain cells that have receptors that it can bind to. So your skin is fine. People are wearing gloves. You don't need to wear gloves. You're not going to acquire the infection going through skin on your hands, particularly. Yes, it could be picked up by your hands. And if you touch your mouth, if you touch your nose, if you touch your eyes, you can spread the virus into the mucous membranes. And when the virus gets in, either through touching that way or through droplets, if somebody were to cough on you, or if you were to kiss or have close contact with somebody that might be a spitter while they're talking, then you're going to acquire the infection. Maybe. That depends a little bit on the mutations of the virus that they have and the viral load that they have and the time of exposure you have. You might hear a little bit about droplets versus aerosolization. The spread is through droplets, which are larger particles that are expelled when a person sneezes or coughs. Those particles are large enough that they'll actually be subject to gravity. So they'll go out and they'll usually fall within about 3 feet or so of the person. Aerosolization requires smaller droplets, and those are generally not what you see with the spread of this virus. Aerosolization could be, and is more dangerous for healthcare professionals, where they're performing procedures like intubation, or they're going to give nebulizing treatments. That's where they can see more aerosolization, and that could be more dangerous. And that's why healthcare professionals have to be more secure with better PPE, which is personal protective equipment, such as N95 masks and such. So the virus is very similar to the flu virus. Actually, a coronavirus is what this is. It's a single-stranded RNA virus, and it will be transmitted just like any other viruses. So how do we prevent that? And where do you see virus spread? Well, you're going to see virus spread when you have more contact. So if you have a high population density, if you have a prolonged contact with a person who might be infected, then you're more likely to catch it, just like the flu. And just like the flu, there's a lot of talk about how bad this virus is. This virus is so much more severe than the flu. The numbers are not panning out. So if you actually track the numbers, right now, the current projections, I follow the one is through the University of Washington, the IHME. They're projecting about 67,000 deaths or so in the United States currently from the COVID. And that's on par with influenza. if you look at the CDC numbers, generally about 40 to 50,000 people die every year in the US from influenza. And remember, the flu is also being suppressed, hopefully, by vaccines. We don't have a vaccine yet for coronavirus, and maybe that's what's scaring people a little bit. But really, the numbers are not panning out. The original models were saying, oh, we're going to have hundreds of thousands, if not millions of deaths in the United States. And that's just not true. You know, the models are, think of it like a weatherman. If a weatherman's out there 1 month before a certain date that you want to know the weather, they're not going to be accurate. They wouldn't have no idea. Maybe a week before, once they've gathered a little more data and getting closer to an endpoint, they're going to be, hopefully a little bit better in their prediction. 1 or 2 days to the end, it's going to be. Same here. The models try to assume certain statistics and particulars. You know, are they practicing social distancing? You know, what's the population density? A little bit of that, and then they put it into a model. Well, the numbers have not panned out, and maybe the people are saying, well, it's because of social distancing. Yes and no. Social distancing helps prevent the spread, but the social distancing was already put into these models. So the original numbers, including social distancing, were just not accurate. There are a lot of numbers out there. It depends. A lot of people might be following the Worldometer, or they might be following the Johns Hopkins website or others. The numbers are not accurate. The numbers are estimates for the most part. Just like if you're following the CDC or the WHO, when you see these numbers, they're only estimates because you cannot get an accurate number. There are many reasons for that, especially here with COVID-19. Every state, every jurisdiction, every nation doesn't report a death the same way. So they don't, it's not a standardized protocol to say, okay, they've had COVID-19. Does that mean they died from it or they died with it? And some states will say, okay, even if they had it and they died, if they might have died of a heart attack, or they might have been a smoker for 25 years, and they could have died from their COPD and the underlying medical conditions they have, but COVID-19 maybe was the last straw, pushed them over, or they just felt it and then they died. Some of those jurisdictions will then say, okay, this person died of their heart attack, or others will say because they had COVID-19, they died of COVID-19. But generally, they try to follow a trend and get an idea of what the numbers that you see out there are not 100%. And they're not necessarily the same from state to state or county to county or nation to nation. And a lot of it depends on how accurately they're reporting. A lot of it also has to do with testing. You know, people are calling, we need to do testing. Well, testing is beneficial for an epidemiologic purpose at this point. Kind of get an idea of how the virus is spread or how it has gone. Well, I'll talk a little more about this here in a little bit. But again, large areas are doing different numbers of testing, and the more you test, the more likely you're going to find higher numbers of infections.
Yeah.
If you don't test, then your numbers can be lower. So that's another bias that could be thrown into the data that's out there. If I can to talk a little bit about the testing, there's two basic types of testing out there that now you might hear in the media. There's the one type of testing is trying to determine if you have the virus. And traditionally, virus testing used to be on viral cultures. You would take a sample, you would culture it on the cells, and you would see if the virus was alive and killed the cells. Nowadays, that's pretty much been supplanted by molecular studies. In this case, what's called Rtpcr, or reverse transcriptase PCR. This type of testing looks for a specific small amount in the genome or in the RNA to see if that's present. But that doesn't necessarily mean you have an active infection. That just means you have had the virus present. To try to give an analogy, say I had a box of light bulbs, and you take those, the old incandescent type of light bulbs, and you take that box and you smash it down onto the floor. Well, you look into the box and you can see a filament, or you might see some broken glass, and you know that's a light bulb, but that light bulb doesn't work. The same thing happens with the virus. The virus could be damaged or destroyed by your immune system, and the particles of RNA can still be around. If they're intact enough, they can be detected by these types of tests. So the test doesn't necessarily say you have an active infection. Now, clinically, if you have the symptoms and then you have the positive test, then likely it's due to the virus. As a pathologist, one of our practices is clinical pathology. I'm a board certified anatomic and clinical pathologist. Clinical pathology, our goal is to assess and supervise the clinical laboratory, which does a lot of testing, like blood testing, urine testing, and such. But it deals a lot with validation of tests. Anytime we bring a test in-house, we need to validate it. And that it requires actually a lot of times a broad study. We have to run controls, we have to run samples, we have to determine, what the range of acceptable positivity and negativity results are. So there's a lot involved. Because this virus came about so quickly and spread so quickly, and there's no way to develop a test very well, they went out and submitted these tests through a system through the FDA called emergency authorized usage. So these tests have undergone very little validation. We don't know that in pathology, you'll study terms like sensitivity or specificity or accuracy. And these are statistical assessments of how good the test is. And these tests, we don't have those characteristics. We don't know. We could have a test that cross-reacts with another virus or with other particles. The biggest problem actually has been what we call false negatives, meaning you might have the virus, but the test ends up being negative because they didn't sample it properly. You might not put the swab deep enough into the nose to get enough sample to collect. So you don't know how accurate it is. So just seeing that you're positive doesn't necessarily mean you have active infection, and it doesn't even necessarily mean you have a real infection. The more you test, when you take a test of any sort, no test is 100% perfect, never has been. We try to get a test that is good, and then once we understand its characteristics, then we can say, well, okay, you've got a 95% chance of this being right or real. And if sometimes we can run other tests, or we can repeat the test to try to determine if it's real. In this case, we really don't have that. We don't know what we call the gold standard. This has kind of out by itself become the gold standard, but we don't really know how good it is. So just because you've tested doesn't mean you have it. And the other part of the problem is if you start testing more and more and more on large populations that generally don't have the disease, you're going to see more false positives. So the other side is, what does the test mean? What are you going to do differently? In this case, there is no specific treatment for coronavirus. So running the tests doesn't necessarily mean you're going to do anything differently to treat the patient. Unfortunately, here is where a lot of the fear comes in, because a lot of it is unknown. Okay, we test you, we say you're positive. Well, if that's real, what are you going to do? If you have mild symptoms, you should stay home, just like the flu. Stay away from others, avoid contact so you don't spread to the people around you. Generally, if you're young and healthy, that's not a problem. There's going to be some people who have underlying conditions that they might develop more severe disease, similar to the flu. This might be, some of the aspects of the disease process might be a little more severe than the flu in some cases, but when we're looking at the overall death rate, at this point, it's not panning out. It's just about the same as the flu. So the call for testing is premature, or there's no scientific basis necessarily to call for that. The other type of testing that we have is serologic. This is the newer one that you might be hearing coming out at this point. And this is for antibody testing to see if a patient has already been exposed to the infection and their immune system has now developed antibodies. So we test this in other infections to see if they've developed the antibodies. That's part of the normal immune response to the body. It'll come in, you have immune cells that will say, okay, here's something that's foreign. I will create this protein to try to bind to it, attack it, to subdue it. And for anybody who's maybe not available or used to this, this is a couple antibodies called Igm and IgG are the two main types. And the serologic testing uses antibodies or looking at the antibodies, but you usually use some kind of antibody to bind to those to see if you have those specific types of antibodies. And there's 70, 80, 90 different companies trying to develop these tests now to see if you're immune. What does that mean? We don't know. The problem here is that these tests already are known to not be very good. They don't have the sensitivity and specificity that you want. When you talk about specificity, you say, okay, does this test say that I only had coronavirus? Well, no, they don't, because these tests can also cross-react with other coronaviruses. That's already known. But we don't know to what degree, because it hasn't been around long enough. They're just coming out in production. But you have these companies making these tests, and we don't really know what they mean. So what would you do with that information otherwise? Pretty much nothing. Unfortunately, I think the people who are making calls for this probably have some financial incentive, because the testing really isn't. So if you say you're positive, are you? Have you really had the infection? Now, if you've been tested with the genetic type of test, and then tested to show your antibodies that you've had an immune response, likely that's real. But if you're just being tested out for no reason, or for a job, or for whatever, it doesn't say you've had that infection necessarily. You could have had another coronavirus. There are 4 or 5 other coronaviruses out there that cause the common cold, and there is known cross-reactivity. So without knowing if that test is really good, it really is not a good test. It doesn't tell you anything. So all the calls for more testing don't make sense to me. And scientifically, they're kind of meaningless.
Wow, that's a lot to get my head around.
Oh, it's a lot out there, and this is just getting started with how the tests work, and really understanding if the test really means anything. In many cases, it really doesn't. And clinically, again, it really doesn't. We don't. The coronavirus does not have a vaccine, as you know. You've probably heard that there are some companies that are already testing some types of vaccines to see if they'll work. But production to go out into worldwide production would be probably at least a year or 2 down. Are we going to keep everything closed down and shut till we have a vaccine? That doesn't make sense to me.
Right. So, being the head of a school, of your school, we're closed right now, like so many schools all across the United States. We're thinking about, what protocols we should be putting in place to protect young people and our teachers when we come back in session. What would be, from your expertise and vantage point, what are the kinds of things you think we should be contemplating?
Well, that's a difficult question to answer. I personally don't think the school should have been shut down to begin with. It was already known early on from the experience in China and Italy and going on in Spain that children really did not have severe symptoms or problems from this virus. It acts just like the flu virus. Kids can handle the viruses a lot better than adults, and most of them don't have the underlying diseases. Another term that may be floating around that you've heard about is called herd immunity. herd immunity basically applies to having enough people in a population being immune to a disease that it can protect the spread of the disease to enough people around them. And if I remember, it's usually around, you want to run a range of 50 to 60% of the people to have already been exposed and have immunity to something to create herd immunity. Well, in my opinion, what's the best population to try to develop herd immunity? Since we don't have a vaccine available, and it's going to be impractical to keep the world shut down for a year or two till a vaccine can be put out, tested, and administered. The children would be actually probably one of the best groups to have the virus spread through if that's the case. Knowing that, I'm sure there's going to be many people that say, oh, how could I expose children? Well, they're generally, they're not going to have any problem. Yes, you're going to hear the one report of a little girl who died of viral meningitis. That happens with the flu. How else can we develop, herd immunity and get people back to daily living without having to go around? Brent, this is not going away. People are, I think, under the misconception that we wait just a little bit longer, it'll be totally gone and we don't have any problems. That's not the case. And it has never been the case. The reason for doing all the shutdown was not to stop it. That was to try, the original models were showing it was going to be such a large number of people that were going to have such severe disease that it was going to overwhelm the healthcare system. So the idea was to try to block that, not let the infection spread so quickly that the healthcare system would be overwhelmed. And for the most part, that has been true. There are your little locations, especially East Coast, New York, where they've had maybe a little bit overwhelmed by it, but it really hasn't materialized in most of the country. So to get back to what would I do for the schools? I would open up the schools. I would still practice some form of social distancing, but you have to follow common sense. This really shouldn't be any different than if you have the flu. If you have the flu, unfortunately, it's probably a bit of the corporate mentality in America. You go to work and you keep working and you got a cold, darn it, you're going to come to work. Well, no. If you've got a flu, if you've got the viral symptoms, you should stay at home and let the flu run so you don't spread it to other people. Yeah. Same thing for coronavirus. It's the same thing. Yes, we know that there are certain populations that are more susceptible, especially elderly, and those people with obesity and diabetes and underlying health conditions such as chronic lung disease and heart disease. The one thing I haven't seen the numbers on, and I would like to see more, is how about smokers? Of course, a lot of this underlying heart disease and chronic lung disease is due to smoking, but you don't see anybody specifically stating that. But I'm sure a lot of the people who are smokers out there are the ones who are more susceptible because you're causing lung damage. And this virus generally attacks in the lung. That's why it's called in the acute respiratory syndrome, acute respiratory syndrome virus. So I think Dr. Oz actually mentioned that too, but he was attacked on social media by people who don't know. If you follow, how the basic virology and microbiology, how viruses spread, you're gonna, have the same precautions. So you want to maintain, so if you have a virus, stay home. If you're more susceptible, either stay home if you can or protect yourself more. Certainly the healthy population is not going to have an issue. Now, face masks. Okay, I have a couple of problems here. There are different types of face masks. In the hospital setting, we use them in an acute setting, and we use them to protect ourselves generally, the physicians or other healthcare employees, from people who have infections or have blood or anything. We use it in an acute care setting where we've done with it, we dispose of it. It's not something we reuse. We'll use a new mask on a new patient. It's not something we're wearing around. Face masks, there's no proven efficacy for face masks. There is no study out there that shows it. And you can't do it because the face masks are too different. You can't just say, okay, this face mask is equivalent to this face mask and this. The other problem is most people don't know how to use them. They don't know how to wear them. When you're using a face mask that seals well, what we call an N95 mask, we have to form that around the bridge of the nose and don't have it around a beard or a mustache so that it actually seal around the face. That will help prevent a lot of the respiratory droplets and anything coming in. A face mask is not going to do that. And even if you look at the CDC guidelines, the CDC specifically states this is not there to protect you. So the face mask it might give you a false sense of security. It's not going to protect you. The main usage is if you're infected or people are now talking about the asymptomatic carriers. If you cough or sneeze, it should catch those droplets, and so you hopefully won't spread it to people. But if you're wearing it to protect yourself, there's no proven efficacy. There's no scientific study at all out there saying that it's any good. In fact, I would counter saying that it's probably going to lead to more infections and more problems for people, because I have seen it even in the healthcare setting. Physicians who know how to use face masks, if they have to put on these cloth masks, they end up touching their face more. They end up readjusting the mask. They're touching. So if you've been touching doorknobs and touching other surfaces that are contaminated, where's that? In your hands. You start touching your mask, you start fiddling with your glasses and your eyes and maybe scratch your nose. You're going to actually probably end up causing more problems. And believe me, there's a lot more vile creatures lurking in the hallways of a hospital than you can find in public. The other problem I have with face masks is people don't know how to take care of them or dispose of them. I'm seeing face masks lying in the parking lots, and they're becoming trash on the sidewalks and in the streets. And really, what's wrong with you people? They should be, taking care of it and throwing it away. Just like gloves. I have a major, how should I say it politically correct? I'm offended by people who take their gloves and throw them in the parking lots. A glove to me is something that I use in the hospital on a nearly daily basis, and that's to protect from bodily fluids, possibilities of infections. I deal with blood, feces, and bodily fluids, fresh tissue on a daily basis. So yes, I have to protect myself, protect my hands. I also deal with toxic chemicals, fixatives, formalins, and I would have to need the gloves to protect myself. But when I'm done, I dispose of them. So seeing a glove disposed on the ground is like seeing a biohazard waste or a used condom disposed of in a parking lot. And it is very disgusting, to be quite honest. And in California, a lot of these gloves are not going to end up into the sewers. If it's in the sewers, it's out into the ocean. So we're going to be having a problem with biohazardous waste going out to the ocean. So please, please, please do not wear gloves. What you do is wash your hands. One of the biggest things and the best things you can do, it's the simplest things, is wash your hands with soap and water. And avoid touching your mouth, touching your eyes. Yes, if you can scratch. I don't need to make you paranoid about touching, but if you've been out into a public area and people around are sick, particularly, I hate to say use common sense, but because that doesn't seem to be as common anymore. But please just wash your hands. Don't use gloves. They're not good. Back to the face mask a little bit. A lot of the public health officials are calling for their use. And even in California, we have different counties mandating it. Again, no scientific proof. And to be quite honest, it's a bit offensive too, because people are touching, and they're touching all over it. And it's not like a surgeon in surgery who puts on a mask, he won't touch it. He can't because of sterility conditions. I will use a face mask when I'm working because I don't want to splash blood up in my face. But that's a one-time use. I'm done. goes away. But if you, and since they are calling for face masks, WHO, by the way, does not have any data to recommend it. CDC is, they tell you how to make them, but again, there's no scientific proof that they actually do anything. But if you make a good mask, the best thing is don't touch it. Don't spread the germs that are on your hands and up into your face, because then it's going to be dirty. And if you start touching your mask and you're touching everything else, you're just taking germs and spreading them all over the place. So yes, if you have a good face mask that you can wash, a simple cleaning in the washing machine should take care of most of the problem. It's just like washing your clothes. And I know that one of the next questions is kind of related to this is probably food. How do you handle your food? Well, again, don't go handling food with gloves. Hands are secure. The reason you have skin is that it creates a great barrier from infections. The only time you maybe protect your skin is if you have a bad cut or some kind of lesion on your skin that makes it more susceptible to developing infections. But that's more to protect yourself from acquiring an infection. But the food generally there's been no study and nothing showing that people are developing the infection from food or from the packaging of that. There are some studies out there showing, yeah, this virus can survive maybe on these surfaces on steel and that for maybe 2 or 3 days. But again, who knows if that's a viable virus? Most of this testing, I believe, was done by molecular methodologies. So it doesn't necessarily mean it's a viral, an intact virus that can still cause infection, but it's at least virus particles that are being detected. Just like there's panic that, oh my gosh, it can now grow on shoes. Well, the only reason that, the best thing I say is don't lick your shoes. In the hospital setting where you might have patients who are coughing, you might have high concentration and the healthcare person is going to walk around. And yes, that could be a model for tracking it into other rooms and they might have to watch for that. But in the general public, there's no reason to worry about.
Yeah, I tell kids that all the time. Don't lick your shoes. It's just really good advice. I also tell them don't lick the railings as they're walking up the stairwell. Don't lick the railings. It's really not a good thing. And then the third advice that I give them is don't pick your nose. Just don't do that.
Good advice. That is good advice.
Hey, Bill, we're getting towards the end of our time, and I want to open it up if there's any questions from anyone who's listening in. Sarah, I'm going to turn it back over to you.
Hi. Well, thank you so much, Bill. That's a lot to digest, and I think that we have a lot of things to talk about. I just wrote down my 2 favorite quotes, though, so I want to share those with everybody. Okay. This is why you have skin, and don't lick your shoes. Those are my favorites.
So, I have to make it a bit amusing, but it's true.
It is true. And as we were going through, there's a couple of questions from Facebook, one which you answered right away, which was talking about the testing and talking about immunity. So that was good. And then Marion Gully wanted to say hi.
Hey, Marion, how's it going?
So those are our questions from Facebook right now. So if there are anybody here in the webinar, if you would like to go ahead and put in something from that Q&A, we can do that now. And while we're waiting, I'll ask the next question that I've got here, which is, what is your favorite Roycemoor memory?
Oh
boy. Oh my goodness. That was what, 20 years ago now? 20, oh boy, I can't even add now anymore. Let's see.
I heard you mention
we're talking 38 years ago. That was 82. My goodness. Oh my goodness. There was actually quite a few. I guess I did quite a bit. I had good memories of being in the plays, in Frank Spica's class in science, skinning a cat and creating a cat skeleton.
I don't think they do that anymore.
No. It was a medical lab scientific cat that then recreated the skeleton. I had to preserve the bones. I also did some trying to make wine for a fermentation experiment in Frank's class. Just so many little bits and pieces that I recall.
That's wonderful. We do have a junior on the webinar here. Her name is Ella Chintagunta, and her question is, do you have any advice for students who are thinking of going into medicine?
Oh, if you have no exposure to medicine, certainly one of the easiest things you can do is check out the local hospitals and look into volunteering. You can have many different aspects of seeing what medical life is like. If you volunteer on the floors, taking care of patients, if you volunteer in the emergency room to see how that works, there's many opportunities in that respect. That would probably be the first thing I would do.
Maybe JST as well.
And JST, if you can set up it. I actually had a little bit of an advantage because I had somebody on the inside that could get me set up with the volunteer experience at BAMC. But if you have some contacts that way, certainly go ahead and use them.
Okay, another personal shout out from one of your classmates, from Ruben Louie. He says, hello from a freshman classmate and wants to know if you still dabble in theater.
Actually, no, I have gotten away from theater at this point. I did have a lot of fun with the with theater and performing plays at Roycemoor, and pretty much once I started in college, I was out of that. I did play in the symphonic orchestra and in the jazz band in college, but then after that, really nothing else.
Okay, here's a more serious question from Wendy Griffin. She's watching on Facebook. She says, do you think that we should not be testing at all? And isn't there some benefit to preventing the spread, even if it's inaccurate?
Actually, no. The main testing would be to give a little guidelines to physicians in the hospital. So the testing would be for those who have more serious conditions and with the need to have a little information to see if they need to treat this patient aggressively or watch them a little more aggressively. But in the general population, it isn't. You wouldn't have, if you have the flu, you don't test necessarily for the flu, especially in young people. You tell them to go home and take care of themselves, and it'll usually resolve. It's only in those patients who would have more serious conditions should the testing really be limited to.
Great, thank you so much.
So,
we have a question from Karina, a second grader. She would like to know if you miss winter and snow now that you live in California.
a little bit. I miss the four seasons. I'm in Bakersfield. We're pretty much hot to cool. But if I want the snow, I've got the advantage. There are mountains around here, the Sierra Nevadas, that I can drive up to, go enjoy the snow, and then I can drive away when I'm done. I don't have to shovel. I don't have to scrape the ice usually. So California has all four seasons available in different areas if you don't mind driving a little bit.
I love it. And then to wrap it up, maybe let's ask you some questions that would be a question that pertains to our students who are watching. Who is someone you personally look up to and why?
Tough question, or just an off the top too. That would be a tough one. People I look up to have been my teachers, who have been excellent teachers. A lot of who I am, I think, comes from a lot of the teachers that I've been exposed to in my education, and a lot of them actually at Roycemoor, notably Frank Spica in science. At that time, I was studying a lot of science and enjoyed it a lot. I had a specific teacher in my elementary school, Mrs. Lineback, who, again, very, very good teacher who promoted, a lot of self-study and study more than what the other students were doing if you had some areas of interest. So certainly I'd say the people I look up to most have been the good teachers in my past.
I would agree with that completely. There are so many teachers that I would like to reach out to, and I often say I wish I could have gone to Roycemoor so that I would have some of these guys that I've gotten to know over the years. Well, Bill, I think that wraps up what we said our time was for tonight.
And before we go, my sincere and deep thanks to Bill for taking time to share your wisdom with us and your expertise. This was really interesting and so current for us because you know, there's so much we're all dealing with personally with respect to COVID-19 and trying to make sense of everything that's going on around us and what we should do ourselves without getting caught up in the fear. I think it's really important.
Yes, I agree. That's hopefully, if anything, that people take away from here is don't be afraid of it as much as the media wants you to be afraid of it.
Yeah.
It's another viral infection. Yes, for some people it can be very serious, but for the majority of the people, it's going to be just like another cold. So don't be that fearful about it. And if I may extend, if anybody has any further questions or they come up with further questions beyond that, you may give them my email or contact information.
Lovely. Thank you, Bill.
Okay.
And one last word of advice directly from the mouth of Dr. Stull. Don't lick your shoes. Have a great night, everyone. Thanks for joining in.
Bye-bye now.
Bye.